Hi everyone, myself Punitesh. Today I am going to present seminar on a topic gross and microscopy of dysgerminoma and yolk-sac tumor. Before going directly into the topic, let us see about germ cell. A germ cell is any biological cell that gives rise to the gametes of an organism that reproduces sexually. And germ cell tumors are composed of number of histologically different tumor types derived from the primitive germ cell of embryonic gonad. Basis of germ cell tumors. The common histogenesis of these neoplasms. The relatively frequent presence of histologically different neoplastic elements within the same tumor. The presence of histologically similar neoplasms in extragonadal locations along the line of migration of primitive germ cells from the wall of yolk sac to the gonadal ridge. The remarkable homology between the various tumors in the male and the female. Example from seminoma to dysgerminoma. Germ cell tumors presumed to derive from the pathogenic transformation of ovarian germ cell, being unique in the fact that they recreate, however imperfectly, aspects of human development. Germ cell neoplastic transformation. This is the classification of flowchart of ovarian germ cell tumors. In that, first mature differentiation contain well differentiated tissues that are benign malignant transformation, and embryonal differentiation undifferentiated and primitive, in that dysgerminoma and yolk sac tumors are the primitive germ cell tumors. This is classification of ovarian germ cell tumors. Primitive germ cell tumors. In that dysgerminoma, this is the most common primitive germ cell tumor and most common malignant ovarian germ cell neoplasm. 0.9 and 2% of all ovarian malignancies is dysgerminoma. 3/4 of patients are between 1 to 30 years old. Median age is about 20 years. Few occur under age 6 or over age 60. Only 4% of patients are over 40 years. It is rare in infants but is most common ovarian malignancy of children, adolescents and pregnant women. 17% of dysgerminomas are associated with pregnancy. It is the most common associated with gonadoblastoma in dysgenetic gonads. Bilateral ovarian involvement is seen in 15 to 20% cases. Ovarian counterpart of testicular seminoma. Elevated serum LDH at presentation. These are the gross features of dysgerminoma. It has variable in size, solid, fleshy tumor with a smooth lobulated exterior, and it is capsulated, firm in consistency, uniform, pale tan to grey pink in cut surface. Focal calcification at the periphery. Dysgerminoma contains only malignant germ cells, up to 1/5 of cases. Dysgerminoma microscopy. Identical to seminoma of testis, mediastinum, sacrococcygeal area, pineal region. Its pattern composed of aggregates, islands or strands of large uniform cells, surrounded by varying amount of connective tissue stroma, composed of cells that resemble primordial germ cells morphologically, histochemically and ultrastructurally, but tend to be smaller. Cells are round or polygonal and are about 20 micron in diameter. When the cells are well fixed, they have prominent vesicular nucleus containing one or more large eosinophilic nuclei. Cytoplasm is clear or slightly granular, contains glycogen and gives positive periodic acid, Schiff stain, and positive alkaline phosphatase reactions. A vague glandular trend may be evident in some tumors, reflecting differentiation towards embryonal carcinoma. Immunokeratin stains are usually negative for APF and HCG but positive for placental alkaline phosphatase. In 2 to 3% of dysgerminomas, rare giant cell resembling syncytial trophoblasts are present. HCG has been demonstrated by immunoperoxidase reaction. About 20% dysgerminomas contain foreign body type giant cells. which, like the presence of diffuse lymphocytic infiltrate, correlate with better prognosis. A rare subtype, anaplastic dysgerminoma, is analogous with anaplastic seminoma of the testis. It has a overall pattern of dysgerminoma, but with more cellular pleomorphism, multinucleated cells, and increased number of mitosis. LDH, PLAP, calcium 125 may be elevated and in some instances can serve tumor markers also. LDH in particular has been successful in predicting recurrence in dysgerminomas. This is microscopy of dysgerminoma is composed of large aggregates of uniform cells. Tumor is also composed of trabeculae of tumor cells surrounded by connective tissue stroma containing lymphocytes. Tumor cells shows centrally placed nuclei with delicate cytoplasmic membranes and also prominent nuclei also seen. Yolk sac tumor, also termed as endodermal sinus tumor because they are derived from primitive yolk sac. Third most frequent malignant germ cell tumor of the ovary, represents about 1% of all ovarian malignancies, and it is also the second most common malignant ovarian germ cell neoplasm. Common age, median age of 16 to 18 years. About one third of the patients are premenarchal at the time of diagnosis. Usual presentation is abdominal pain with large abdominal or pelvic mass, commonly extra ovarian spread, peritoneum, retroperitoneal nodes, or pelvic pain, and the presentation is acute. Half of the patients have symptoms for 1 week or less. Patients usually do not have endocrine or menstrual abnormalities. Serum HCG is also not elevated. Tumor marker, elevated serum AFP is also almost always present. A very high level is suggestive of the diagnosis. Gross features. It is the unilateral in 100% of cases, therefore, biopsy of opposite ovary is contraindicated. Usually large, oval shaped, encapsulated, firm, and grey brown. Majority being over 10 cm in diameter. The cut surface of the yolk sac tumor shows solid and cystic with necrosis and hemorrhage. This often leads to rupture and spillage at the time of surgery. Tumor may form adhesions to the surrounding structures and invade them. These are the gross appearance of the yolk sac tumor. Yolk sac tumor microscopy patterns are like this. Microcystic or reticular are composed of loose network of small cystic spaces forming a honeycomb pattern. The microcysts are lined by flat cells with pleomorphic and hyperchromatic nuclei. Myxomatous, small collections of epithelial-like cells forming strands or gland-like structures, are seen within abundant myxomatous tissue. Endodermal sinus are composed of perivascular formations consisting of narrow band of connective tissue with a capillary in the center and lined by layer of cuboidal or low columnar epithelial-like cells. The cells have large vesicular nuclei and prominent nucleoli. This structure are known as sinus of dual or scalar dual bodies. The presence of these structures can be considered diagnostic of yolk sac tumor, but their absence does not exclude the diagnosis. Alveolar glandular tumor cells are arranged in alveoli, acini, glands, or cyst-like spaces. Polyvesicular, composed of numerous small vesicles surrounded by connective tissue. Tumor cells are arranged in papillary projections, and hepatoid pattern composed of solid aggregates or cords of polygonal cells with cells or granular eosinophilic cytoplasm resembling hepatocytes. Hyaline bodies may be present. Glandular or primitive endodermal. They are lined by cuboidal to columnar malignant. This is the YST or yolk sac tumor microscopy. The cell features of yolk sac tumors consist cytoplasm of moderate amount and pale to clear, and nucleus is of hyperchromatic irregular and prominent nucleoli is seen, and mitosis commonly occurs. The cells lining microcytic spaces may be flattened and less obviously malignant in appearance. Scalar dual bodies. It is only seen in 20% of tumors, rounded to elongated papillae with fibrovascular core, and is enshielded by primitive columnar cells. The papilla may occupy a space lined by cuboidal, flat, or obnale cells. Scalar dual bodies are usually sparse, but when numerous, create a distinctive endodermal sinus pattern. Eosinophilic, PAS positive, diasterase resistant island bodies of different sizes are present in most yolk sac tumors, being most numerous in areas with a reticular or hepatoid pattern. This is the microscopic pattern of yolk sac tumor. The marked region shows the scaval dual bodies in the microscopic pattern of yolk sac tumor. These are the like uh, special strains like PAS positive, diastase resistant island bodies, and IHC strains like AFP cytoplasmic patchy, alpha antitrypsin 1, SALL4, Glypican 3 cytoplasmic, AE1 or AE3 cytoplasmic, LIN 28. Thank you.